All right, so we've talked a little bit about basics. Now we're going to get into health assessment for women's reproductive health. First of all, when we're taking a history of any kind, we need to ensure a private environment, but especially when we're talking about things that may be more sensitive for certain patients. So we want to make sure we provide privacy and promote comfort. We want to begin an assessment with open-ended questions if we're trying to get a full assessment. You want to develop rapport. You've learned by now that patients give more information and more accurate information if they have some trust in you, if you've developed something of a therapeutic relationship. That's even more true for reproductive health. You really want the patient to feel a connection to you and some trust so that they are able to give you more honest information or more complete information, and you can provide better care. We want a general health history. We want to know if we have a reproductive concern, we want to know about menarche. When did that person have their first menstrual cycle? We want to know if they've had any menstrual problems, and want to know their obstetrical history. And later on in the next unit, you're going to get a real specific way to document obstetrical history, which is how many pregnancies and babies and all that they've had. But for right now, just know you're going to need to know about how many times they've been pregnant, how many times they've had a baby, what was the result of those pregnancies. On the physical exam, we want to do a head-to-toe assessment. There are common hormonal problems that actually are going to cause symptoms in other systems of the body, so don't focus just on the reproductive organs. If we have a reproductive concern, we might be doing an external inspection and palpation of the genitalia. That's going to be done routinely at a gynecologic visit. We don't do that routinely on every patient we see because it's very invasive. But if there's a concern, we might be doing that. We want to teach patients to be familiar with their own bodies and to let someone know to see a provider about changes. An internal exam with speculum has to be done by someone who has been trained to do that. That can be used, a speculum can be used for a pap smear, to get cultures, or samples for microscopic examination, and to examine the vaginal walls. It also allows for visual inspection of the cervix. Bimanual palpation, again, is done by someone who's been trained to do that. And the pelvic organs are trapped between an external hand on the abdomen and an internal hand that's in the vagina. Part of a full exam may also be a rectovaginal palpation, to palpate if there's any, whether there's any abnormalities between the rectum and the vagina. Health screenings, follow the guidelines on page 59 of Perry. So there's a whole set of guidelines. Those change fairly frequently. I don't tend to test real heavily on those because they change every few years, but the current ones as of when this book was published are on page 59 of Perry. Some special considerations. Caregiver concordance. And we've already talked about cultural concordance, that sometimes patients are more comfortable with someone from their own culture. But in reproductive health, some people may be more comfortable with gender concordance as well. Some people are more comfortable if the gender of their caregiver matches their own gender for reproductive care. So be aware of that. If you are male and you are going, as you're going into this semester, you're going to have to be aware that there are some women who are going to be really uncomfortable with you being present for reproductive care. Typically, we are able to get male students some experiences in OB. We just have to be a little more creative with it. Okay. For adolescents, the history is the same as adults, but we want to ask about risky behaviors. eating disorders, depression. Honestly, I would also want to ask about those things with adults as well. We want to establish rapport with adolescents before we discuss sexual activity. You don't want to ask about sexual activity with a parent in the room. You're not likely to get an honest answer if that child is sexually active. You want to be non-judgmental and don't show shock. If you show that you're shocked, sometimes kids are looking for shock, but if you appear to be shocked about behavior, some kids will also shut down and not give you any information. You want to make sure you're teaching while you assess. Something else that I've seen, you don't want to ask kids, are you sexually active? Because they may not really understand the meaning of that to be, have you ever had sex? So you want to be more straightforward. Be really cautious about using euphemisms because they can be misunderstood. So I would just ask a teenager, have you had sex? Or are you having sex with anyone now? Because you want to make sure that you're getting accurate information. For women with disabilities, this is a major issue in disability care, something a lot of people are not aware of. And there's some things that we may do unconsciously that can be problematic. It's very common if someone has a disability for healthcare professionals to speak to whoever's with them instead of to that person, and to treat them as if they were a child or an inanimate object. So make sure that you speak to the client rather than the family as much as possible. Involve the family only as is necessary and desired by the client. If your patient has sensory deficits, make sure you're communicating during the exam so that you're not just touching them unexpectedly and they're unaware of it. If someone has physical disabilities, then we may need to do some positioning adjustments for examination. If they have emotional or mental health challenges, you want to communicate clearly, be sensitive, and be aware of the potential for triggering PTSD. Okay. Also be aware of the potential for misinterpreting actions if someone has mental health concerns or has a history of abuse. For a patient with cognitive disabilities, you want to explain whatever you're doing to that client's ability to understand what's happening. After a hysterectomy, other special considerations. After hysterectomy, a pap test is not recommended if the cervix was removed and there was no cancer. So it's for benign disease, that means no cancer. Vaginal walls may be sampled for HPV or pap every 1 to 3 years, and that's definitely going to need to be done if there was previous cancer. Okay, so the next thing we're going to come back and talk about is some risk factors to be aware of.